Hello, my name is Lauren Carnes, and I will be presenting the pathophysiology of impetigo. Impetigo is a very common infection which affects the superficial layers of the epidermis. It is highly contagious and is most commonly caused by gram-positive bacteria. It is also known by group A Staphylococcus or Streptococcus aureus or both. It is an infection that can be bullous or non-bullous, which I'll explain later. Also, it has been reported to cause MRSA and gentamicin resistant strains have been reported to cause impetigo as well. Non-bullous is most common by Staph aureus or group A streptococcus or a combination of both. Non-bullous is responsible for most diagnosed cases, and it also starts as a vesicle or pustule on the skin. Bullous impetigo is caused by Staphylococcus aureus, and it can be classified, impetigo can be classified as either primary or secondary. Bullous impetigo typically, initially, it will start with small vesicles with clear or yellow fluid, and it'll appear to become flaccid with dark purulent fluid. Once the bullae ruptures the rim or around the base, just as remaining. Non-bullous impetigo, initially there's multiple vesicles or pustules present. Once the vesicles rupture, then you'll see the honey colored crust that forms with the purulent exudate, which you can see in the pictures below. This is more of a rapid spread, and it's called what they call satellite lesion formations will occur. Let's see. There is also impetigo to be classified as either primary or secondary, primary being a direct bacterial invasion to the skin, and the secondary involving the infection to form at a previous wound site. The infection spreads outward in the incubation period for colonization on the skin to lesion developing is about 10 days. It also can affect deeper tissues of the skin. The risk factors, it is most predominant in young children ages 2 to 5, but it can occur at any age. Activities where cuts and scrapes are common. People with scabies infection are at higher risk. Close contact or crowding. Typically, it happens in more hot and humid climates. Poor hygiene, insect bites, immunosuppression, contact with infected items, and pre-existing chronic dermatitis. Some complications, if it is not treated, is renal dysfunction, septic arthritis, scarlet fever, sepsis, and staphylococcal scaled skin syndrome. As you can see below in the pictures, what I talked about above for the non-bullous, where it will develop those honey-colored crusts on the lips, mouth, nose, and hands. And then you can see it can start as red, itchy sores that break open and leak clear fluid. As far as diagnostic testing, typically the diagnosis happens upon clinical assessment. Typically, there isn't any cultures taken upon diagnosis, but if there is a culture taken, it can show that the gram positive will happen in pairs or clusters. Non-pharmacological treatment, maintain good skin hygiene, washing of the hands. You can cover loosely with bandages, and education to parents. Typically, also after, say, an antibiotic treatment to the skin, if that is not clearing of the impetigo, there can be an oral form antibiotic prescribed as well. Typically, the child with a diagnosis of impetigo after medication can return to school 24 hours after. Okay, great. Thank you very much. And I hope you enjoyed the presentation.